My name's Katie. I'm one of the 5th year medical students at University of Liverpool. I'm going to chat to you today just a little bit about some gynecological emergencies. So I'm going to start off just kind of by defining what I think a gynecological emergency is. So it's a disease condition of the female reproductive system that threatens the life of a woman, her sexual function, or the perpetuation of her fertility. And I think it's important to kind of understand that, to understand about why I'm going to talk about what I'm going to talk about today. So the topics that I'm going to cover include miscarriage, ectopic pregnancies, molar pregnancies, pelvic inflammatory disease, ovarian cysts, ovarian torsion, and then toxic shock syndrome at the end. Just a slide on that. I don't think it's something that you really need to know in terms of for finals, but it's a gynecological emergency, so I thought I'd include it. So I've got a couple of questions kind of dotted around, and hopefully I'll then explain the answers in the teaching. So we're going to start off with one of them. So a woman presents for her 3-month dating ultrasound scan, and she describes an uneventful pregnancy to date with no abdominal pain, no PV bleeding. So on this ultrasound scan, it reveals a fetus of 8 weeks gestational size with no fetal heartbeat detected. So can you classify this miscarriage? So the options are A, incomplete, B, missed, C, complete, or D, threatened. So I'll give a couple of minutes for people to vote on the poll, and then once there's about 70 or 80% of you voted, then I'll close it and we'll go through the answer. So I'm going to end it there. So most people have gone for missed miscarriage, but there's a couple of people going across all the different answers. So let me just close the poll. So the right answer is B, missed miscarriage. I'm going to go through all the different types of miscarriage, but in this case, this lady hasn't had any symptoms, but unfortunately the fetus isn't the size you'd expect. So the dating scan, you'd expect a 12-week fetus, and this fetus is only 8 weeks gestational size. So talking a little bit about miscarriage. So it's defined as a pregnancy that ends spontaneously before 24 weeks gestation. And it's really quite common. I think it's underappreciated how common miscarriage actually is, because I don't think it's spoken about. It's not normalized that much. And so people are quite shocked when they realize actually about 20% of clinical pregnancies do end in miscarriage. And on top of that, there's also the pregnancies that are undetected miscarriages. So where a lady will get pregnant and miscarry without even realizing she was pregnant in the first place. So if a woman does present, it's often with vaginal bleeding, abdominal cramps and pains, but it's very specific to that woman. So some people present in extreme pain, some people get a little bit of pain. It does vary between patients. So what causes miscarriages then? So fetal, genetic and chromosomal abnormalities are the single most common cause of a miscarriage. And we don't really know why that happens. There are some other causes, so medical and endocrine disorders, often women who have issues with thyroid, if they're hyperthyroid or hypothyroid, can often struggle with miscarriage. And then also things like uterine abnormalities, any maternal infections, or any drugs or chemicals that are added to the body. So how do we investigate these women? So start off with an A to E assessment. So any woman that presents with vaginal bleeding or severe abdominal pain would warrant an A to E assessment. And then in terms of the actual diagnosis, a single ultrasound scan is enough to diagnose a miscarriage. Often transvaginal ultrasound scans are preferred, and that's purely based on that it's easier to see the smaller fetuses. But if that's not possible, or if the woman doesn't like it, then you can do transabdominal as well. And then obviously in any woman who's presenting with blood loss, whether it's PD or any type of bleeding or blood loss, you want to do a hemoglobin and check that, and also a group and save in these women. Now, if somebody presents with really severe PV bleeding, you're probably going to want to cross-match them, but that's not appropriate in every situation. A group and save is normally sufficient for these types of patients. So a little bit about the types of miscarriage then. So this goes back to the answer to the question. So a threatened miscarriage is when you get vaginal bleeding and abdominal pain in a woman. When you examine her, her cervical os will be closed, and on ultrasound there'll be an intrauterine pregnancy and there will be a fetal heartbeat present. So I've got a picture at the bottom there just for you to have a look at. So in this case, the fetus is still alive. However, there's early signs that this woman may well be miscarrying. So not everybody that presents with and that's diagnosed with a threatened miscarriage will go on to miscarry, but unfortunately the majority do. Then there's an inevitable miscarriage, and this is where you have vaginal bleeding with abdominal pain. The cervical os is open, and there's an intrauterine pregnancy without a fetal heartbeat. So unfortunately in this case, the fetus is no longer alive and the cervical os is open. So you'd expect this lady to miscarry, and there's a picture kind of showing the difference between cervical os being closed and the cervical os being open. So then incomplete miscarriage is where you get vaginal bleeding with abdominal pain, the cervical os is open, and you can see the products of conception, and there may or may not be retained products of conception. And this, sometimes this will lead to the retained products of conception, but often this can just become a complete miscarriage. And a complete miscarriage is where there's pain and bleeding that's resolved, the cervical os is now closed, and there's an empty uterus on ultrasound scan. And that looks like that picture. And then finally, a missed miscarriage. So this is what I was referring to in the first question. So these women are often asymptomatic, and they're commonly diagnosed at booking or dating scans. So they're often, a woman finds out they're pregnant, has absolutely no symptoms, turns up for the 12-week scan, and the fetus unfortunately doesn't have a heartbeat and is smaller than they would expect. And there's an intrauterine pregnancy without a fetal heartbeat. And there's a picture of kind of what that looks like. And like I said, these women don't have any symptoms, they don't often have bleeding, they don't have the pain, but unfortunately there is no fetal heartbeat. So talking about the management of these then. So there's a couple of different options for management. So there's expectant management, there's medical management, and the surgical management. So I'll talk about each one of them, and then I'll discuss when you do which one. So following investigations, often patients are sent home for the pain and the bleeding to resolve. I think miscarriage is, I can only imagine it's a very traumatic experience for a lot of women. And I think being in hospital isn't always helpful for them, and actually being at home in a familiar place surrounded by people who can look after them and love them is really important. So they can go home for it to resolve, and then they should take a pregnancy test at 3 weeks post miscarriage, and they need to reattend if that remains positive, but in the majority of cases that will then be negative. And these women don't require another scan, so you don't have to rescan them. So the medical management then, this is vaginal or sublingual prostaglandin E analog, misoprostol. You can give pre-treatment with the progesterone antagonist mifepristone, and there's variable practice around this, and it's normally local guidelines that will indicate whether or not to use it. There's been quite a bit of research recently that shows it is useful and it has good outcomes, but traditionally it's not always used, and you cannot use it in a missed or incomplete miscarriage. Medical management does have side effects, and that's why it's not offered to all women, and why expectant management is used. And that's things like pain, vomiting, and diarrhea. it's not particularly pleasant for a woman who's already going through a very traumatic time. And there is a 10% failure rate. And if this happens, these women would go on to require surgery. So surgical management. So when clinically appropriate, you should offer women manual vacuum aspiration under local anaesthetic, or actually more commonly under general anaesthetic. And at the bottom, there's just a little diagram just to try and explain what we mean by this. And it just kind of shows the surgical procedure. So the first step of it, and then the second step of it, where you actually vacuum the uterine lining out. So in terms of when to do what, I've taken this directly from the NICE guidance, because I don't think it's that clear actually, but this guidance is. So you would use expectant management for 7 to 14 days as the first line management strategy for women with a confirmed diagnosis of miscarriage. So there are other options. So this isn't kind of like a you must do this. So if a woman is at increased risk of hemorrhage, or at increased risk of the effects the hemorrhage might have on her, then you might consider other options. You don't want to send a woman home who's going to hemorrhage and become very unwell. Any woman that's had a previous traumatic experience associated with pregnancy actually might prefer to have some kind of management and maybe be kept in hospital. I think when things have gone wrong previously, for some women, it can be really reassuring to be in a hospital environment. And if there's any evidence of infection, so if the woman's spiking temperatures, if she's more tachycardic, more tachypneic than you'd expect, any kind of red flag signs for infection, you wouldn't really send her home for the expectant management. So then the other options are your medical and your surgical. So you'd offer medical management to a woman with a confirmed diagnosis of miscarriage if expectant management isn't acceptable to the woman. So this is all about individualised medicine and giving that patient the choice. So if she doesn't want expectant management, she's more than within her rights to ask for medical management, and you should give it based on them grounds. And surgical management is preferred if there's persistent excessive bleeding or hemodynamic instability. So, I mean, I think it's quite obvious that if a woman's really bleeding, she's really in pain, you're not going to send her home and tell her that it will pass, because you need to intervene, you need to monitor her, and you need to do something about it. So that's all of miscarriage. So I've got another question now, which will lead us into my next section. So a 23-year-old woman presents to A&E complaining of severe right iliac fossa pain. She also mentioned she's got a niggling pain in her right shoulder, which she's had for a couple of days. She's not noticed any PV bleeding. She smokes 20 cigarettes a day, and her last menstrual period was the 1st of the 4th, 21. What is your top differential diagnosis? So the options are ovarian torsion, miscarriage, ectopic pregnancy, or appendicitis. So I'm going to end the poll there because most people have voted. So I think most people kind of got this one. So yeah, so the right answer is ectopic pregnancy. So I'm going to talk a little bit about ectopic pregnancy and why this case should make you think she's got an ectopic pregnancy. So ectopic pregnancy refers to any pregnancy that develops outside of the endometrial cavity. So this can be absolutely anywhere outside of that cavity. So it can be a tubal ectopic pregnancy, it can be abdominal, it can be cervical, yeah, just anywhere that you wouldn't normally want a pregnancy to implant, and it affects about 1 in 90 pregnancies in the UK. So 97% of them develop in the fallopian tubes. This picture demonstrates really quite nicely all the different places that it's most commonly seen. And the ampulla of the tube is the most common site for this. So in terms of risk factors for ectopic pregnancy, we get taught quite a lot of different ones, but actually the majority of women have absolutely no identifiable risk factors. But the ones to be aware of is any woman that's had a previous ectopic pregnancy, any woman that conceived with IVF, any history of fallopian tube damage, so that's any previous surgeries around that area, any adhesions. If a woman smokes, in terms of an IUD, it's if the woman conceives while she has an IUD in, her chance of ectopic pregnancy is increased, but obviously the chance of conceiving with an IUD in is very, very small anyway. In terms of clinical features then, these patients, like in the question, have abdominal pain, PV bleeding, and they get this quite typical shoulder tip pain. They have, in more severe cases, they can get rebound tenderness, peritonism, abdominal distension, and these are signs that something's going really, really quite wrong inside. Ectopic pregnancies can rupture, which I will talk about in a little while, and the peritonism and the rebound tenderness are often signs of that. They also get cervical motion tenderness on bimanual examination. So diagnosis, transvaginal ultrasound scan, first line, probably the best investigation for this. You get good visualization this way, and it identifies the majority of tubal ectopic pregnancies, and also serum beta-HCG measurements. So the management of these, so again, this is split up into expectant, medical, and surgical. So women who are clinically stable and pain-free have an ectopic pregnancy that's quite small. So I've kind of defined it on the slides, but I don't think you really need to know the figures in terms of size, but a smaller ectopic pregnancy without a visible heartbeat, lower serum HCG levels, and importantly, in a woman who's able to return for follow-up, can have expectant management. So that just involves coming back and having serial serum beta-HCG measurements, and this would be on days 2, 4, and 7, and then weekly, and you'd need to see a fall of over 15% at each management to allow a woman to continue to have expectant management. So in terms of medical management then, so this is a little bit not that certain. So women who have no significant pain, and obviously we know pain isn't set in stone, like different women experience different types of pain, but in any woman who has almost tolerable pain, have an unruptured ectopic pregnancy that's quite small without a visible heartbeat, and they have a serum HCG level less than 1500, can have single dose methotrexate. And that's the kind of medical management that we use for ectopic pregnancies. It's really important, and I know it sounds obvious here, but they mustn't have an intrauterine pregnancy. So you've got to be dead certain that their only pregnancy is the ectopic pregnancy, and that they haven't also got an intrauterine pregnancy, because you cannot give methotrexate to them people. Surgical management then, so you would do a salpingectomy over salpingotomy if contralateral tube is healthy. So if the contralateral tube is damaged, or that woman has any other facility-based concerns, then you can consider just doing a salpingotomy. And you'd offer this first line to any woman in significant pain if she's got quite a large adnexal mass, so if it's quite a large fetus already, or if there's a fetal heartbeat visible, you'd also offer surgical management to these women. I think when a woman comes in, if she's stable and pain-free, then you'd feel quite happy to do expectant management. Then I think the way I often think about it is any woman who's kind of got some symptoms but is stable, you can try the medical management with them. anyone that comes in hemodynamically unstable, in severe, severe pain. You know, when you look at somebody at the end of the bed, you can tell. And then women do require surgery, and it's important that that surgical management is first line, because it is a matter of urgency, because ruptured ectopic pregnancies are really, really life-threatening. So I've put here, an untreated ectopic pregnancy can lead to the fallopian tube rupture, and the resulting blood loss can cause hypovolemic shock, organ failure, and death. And I think it's really important to realise the severity of this. And actually, it means you really need a high suspicion of ectopic pregnancy in any woman that presents with these symptoms and a positive beta HCG. So it's just making sure you always think about ectopic pregnancy as a differential. Even if the woman's adamant she's not pregnant, if she presents with PD bleeding, abdominal pain, you really need to consider, could this be an ectopic pregnancy? So I'm going to move on and have another MCQ. If anyone's got any questions, you can pop them in the chat. I won't see them now, but I'm more than happy to answer them at the end. So the next question. So an 18-year-old female patient presents to the early pregnancy unit complaining of severe nausea and vomiting. She's vomited over 10 times today and has noticed that she's only passed a very small volume of urine. Based on her last menstrual period, she's around 8 weeks gestation, but she's yet to have a formal dating scan. Up-to-date pregnancy has been uneventful, and she has an ultrasound scan today that reveals a snowstorm appearance. So what's the most likely diagnosis? So the options are partial hydatiform mole, twin pregnancy, retained product of conception, or a complete hydatiform mole. So I'll give you 10 more seconds and then I'll end the poll. Okay, I'll end it there. So in terms of the results then, so 60% have gone for complete mole, about 30% for partial, and a couple of people in between. So the majority of you are right. So the correct answer is complete hydatiform mole. So I'm going to go on and talk about molar pregnancies and gestationaltrophoblastic disease, and hopefully explain the answer to the question to you guys a little bit more. Molar pregnancies then. So hydatiform moles are chromosomally abnormal pregnancies that have the potential to become malignant. So there's two main types. So there's a partial molar pregnancy and a complete molar pregnancy. So in a partial molar pregnancy, you get one ovum with 23 chromosomes, and that's fertilized by 2 sperm or by 1 sperm whose chromosomes duplicate. And that leaves you with a fetus with 69 chromosomes, but of some of maternal and some of paternal origin. So these are pregnancies that may contain histological or macroscopical evidence of fetal parts. So there might be evidence of a fetal circulation, general fetal limb parts, but they have 69 chromosomes and they're not compatible with life. A complete molar pregnancy occurs when there's one empty ovum and it's fertilized by 2 sperm or by 1 sperm whose chromosomes duplicate. And that's 46 chromosomes, but they're all of paternal origin. And these pregnancies have no resemblance to any fetal parts whatsoever. So unfortunately, they are classed as tumours, and they're usually benign, but they can become malignant. And if that happens, they can invade into the uterine myometrium and disseminate around the body, and that's known as an invasive mole. So clinical features. So these patients will often present with vaginal bleeding and abdominal pain early in pregnancy, but this isn't always the case. They will have a uterus larger than expected for gestation of the baby. And it's often, this sounds like a really strange thing to say, but like a soft, boggy consistency. And because it's larger than you'd expect for gestations, we know this consistency because it can actually be palpated a lot earlier in pregnancy. So like in the question, this woman presented with nausea and vomiting and reduced urine. So what I was trying to get across is that she was presenting with hyperemesis. And that's because molar pregnancies let off a really, really high level of beta-HCG. And this causes hyperemesis and hyperthyroidism to the point of almost like a thyroid storm kind of process. And often hyperemesis is one of the first presentations because these women will have a positive pregnancy test, and until they have an ultrasound scan, they won't be aware of the fact that it's a molar pregnancy, unless they have severe hyperemesis, and then like in the question, they would come into hospital and it could be detected then. So diagnosis is by ultrasound scan. So the snowstorm appearance was kind of the giveaway in the previous question. So this is in complete molar pregnancies. You get this classical snowstorm appearance, which I've got on the next slide for you to see. Partial molar pregnancies are actually a lot more tricky because, like I said, they can contain fetal parts and have a fetal circulation, but they're not compatible with life with 69 chromosomes. These guys need serum beta-HCG measurements. They're often very, very, very high, and that's also a giveaway sign that this potentially could be a molar pregnancy if they haven't had an ultrasound scan. And then you need to do histological examination of the products of conception to determine exactly what was going on and its malignant potential. So in terms of the management, so the Royal College of Obs and Gynae recommend suction encouragement as the most effective treatment for these women. So this would be surgical management to remove the pregnancy. So this is the snowstorm appearance. So it's not the best image, but it kind of shows exactly what I'm trying to talk about. So I think another way of it being referred to is almost like a bunch of grape appearance. So it looks a bit like a bunch of grapes. And this shows a complete molar pregnancy. There's absolutely no resemblance to any fetal parts. This is a really significantly large uterus for what you'd expect. So that's the appearance on ultrasound scan. But like I said, it's really a lot more difficult in partial molar pregnancies. So why are we so concerned about molar pregnancies? So not only is it a non-viable pregnancy, but it can lead to gestationaltrophoblastic disease. So that's what I'm going to talk about now. So this is a term used to describe a group of pregnancy-related tumours. So pre-malignant pregnancy-related tumours are your partial moles and your complete moles. Now, those tumours that are already malignant are invasive moles, choriocarcinoma, and placental trophoblastic site tumours. I've got some pictures of all these on the next slide, so hopefully it will clear things up a little bit. So the risk of a post-molar neoplasm is almost 20% of those for those with a complete molar pregnancy, and that's why it's really important that it's recognised and that it's treated. So risk factors for gestational trophoblastic disease include having maternal age, being kind of like almost at the extremes, but I don't think it's particularly that extreme, but any woman under 20 or over 35. Any previous gestational trophoblastic disease, and unfortunately having had previous miscarriages is a risk factor. So diagnosis then, so your serum beta-HCG acts as a tumour marker, and that's really important because it's you can follow these patients up with beta-HCG measurements as almost like a post-molar regression. Chest X-ray is really important to look for pulmonary nodules, because this would represent metastatic spread. And if you're going to get early metastatic spread, it will be to the chest. And then histological examination of placental tissue, and this will tell you its malignant potential and its ability to spread and invade different organs. So management then. So we use chemoprophylaxis for women who have had surgical removal of a complete molar pregnancy. And that's to prevent invasive moles and to prevent full gestational disease from developing. And this is with methotrexate. And then in terms of if women are unfortunate and they have invasive moles or choriocarcinomas, then you can use chemotherapy with methotrexate and actinomycin. So the rate of cure is really good, actually. It's 95%. And often these women actually have their fertility preserved. But this doesn't mean that it's not really important to make sure that it's noticed, recognised and managed appropriately. There's a gestationaltrophoblastic disease like service and centre, and it's really important that all women that have molar pregnancies are referred to these guys, because they can give them like the psychological and emotional support that they will need alongside the medical management that can be provided in the hospital. And also they will make sure this woman gets followed up, and it's just kind of good practice. So this, I'm hoping, is going to help explain what I've been talking about a little bit better, because if you've not heard of molar pregnancies before, it is quite a confusing and difficult topic to get your head around. So the first picture kind of represents a complete complete hydatidiform mole. So this is, as you can see, kind of that bunch of grapes appearance that people talk about, where there's absolutely no resemblance to a fetus there. Then you have a partial hydatidiform mole where you can see there are some fetal parts, but you can also see the abnormalities there in the placenta. The invasive mole down on the bottom row just shows how a complete molar pregnancy can invade into the walls of the uterus, and how that can then lead on to a choriocarcinoma, which shows the invasion through the entire wall of the uterus and metastatic disease. I wouldn't worry too much about the other two pictures, so the coexistent mole and live fetus and the placental site trophoblastic tumour. I think they're probably out of the remits of finals. So we're going to move on to another MCQ. So a 20-year-old female patient presents to her GP complaining of a week's history of worsening lower abdominal pain. On further questioning, she also admits that she's had this deep pain during sexual intercourse. She reports having multiple sexual partners recently, and on bimanual examination, she has cervical excitation. What would be your top differential? So the options are ectopic pregnancy, simple chlamydial infection, pelvic inflammatory disease, or endometriosis. So I'm going to end that there. So the majority of you got it right. So it's pelvic inflammatory disease. So just quickly going through some of these answers then. So in terms of why it's not endometriosis, and so people with endometriosis do often get this lower abdominal pain, and it can come and go in a cyclical phase during their menstrual cycle. And they can often get this deep pain during sexual intercourse. However, on bimanual exam, she's got this cervical excitation, and this is quite a short history of, a relatively short history of pain, a week. So that's why we wouldn't really think endometriosis. In terms of simple chlamydial infection, so she's got some things here you wouldn't really expect with chlamydia in terms of a simple infection. So it's this longer history, and again this pain that she's describing during sexual intercourse. going to talk a little bit about pelvic inflammatory disease. So this refers to an infective inflammation of the upper genital tract in females. So this includes the endometrium, the uterus, fallopian tubes, ovaries, and also it can extend as far as into the peritoneum. So in terms of etiology then, so the most common causes are gonorrhea and chlamydia. And this is when infection is untreated. So if a female gets an STI, doesn't realise she's got it because they often can be asymptomatic, and then doesn't require adequate treatment in a timely manner, doesn't receive the adequate treatment in a timely manner, then she can go on to get pelvic inflammatory disease. But it's also important to remember that not everybody with pelvic inflammatory disease has a sexually transmitted infection, and that it can actually be caused by instrumentation of the cervix. So this includes any gynae surgery and also insertion of an IUD. So I've only ever seen 2 patients with pelvic inflammatory disease, and both of them actually had it from post-insertion of a Mirena coil. It is most common following gonorrhea or chlamydial infections, but it's also important to note that that's not the only cause. So in terms of risk factors then, being sexually active, aged 15 to 24, so it often affects younger women, having multiple sexual partners, having had a history of STIs, and then recent instrumentation of the cervix. So clinical features, they have a lower abdominal pain, this deep dyspareunia, which is the pain that they have experienced during sexual intercourse. They can get menstrual abnormalities and post-coital bleeding. Some women will have an abnormal vaginal discharge, but often this will have been going on for longer than the pain history, and that's because this is actually a sign that they have an STI and they're ignoring it, or they're not receiving the correct treatment for that. And then a giveaway sign is a cervical excitation on bimanual palpation. So in terms of investigations then, if you suspect pelvic inflammatory disease, you need to do some endocervical swabs and a full STI screen. This is really important because even though if someone's negative for all STIs, it doesn't mean they haven't got pelvic inflammatory disease. You would just think, if they've not had recent cervical instrumentation, am I missing? Is there something else going on that I'm missing? But if you get a positive chlamydia or gonorrhea test, then you can be pretty certain of your diagnosis. You need to do a pregnancy test and a transvaginal ultrasound scan. So management is 14 days of broad spectrum antibiotics with good anaerobic cover. So this varies from trust to trust on exactly what you would give and whether it be oral or IV. But broadly speaking, you'd use kind of doxycycline, ceftriaxone, and metronidazole, and that seems like a lot of antibiotics, but it's really important that you get on top of this in terms of it causing issues with future fertility and kind of future sexual function. So I have another MCQ. I think this is the last one. So which of the following ultrasound findings with a Doppler would suggest a possible diagnosis of ovarian torsion? So I think I'm going to end that there. So it's a little bit of a split. About 64% went for ovarian enlargement with decreased venous flow, and about 23% for ovarian reduction. So the correct answer is A, so ovarian enlargement with decreased venous flow. So I'm going to talk a little bit about ovarian cysts, and that will lead us nicely into ovarian torsion, where I'll explain the answer to the question. So ovarian cysts are defined as a fluid-filled sac in the ovarian tissue. Worldwide, about 7% of women have ovarian cysts at some point in their lives. They're really quite common, often go undiagnosed because they're asymptomatic and often don't cause any problems to the women. Transvaginal ultrasound is the investigation of choice for diagnosis. Benign ovarian cysts, so they're, like I said, they're commonly asymptomatic, and the majority of patients who present with an acute complication of them. And that's often things like hemorrhage, torsion, or rupture, which we'll talk a little bit more about. A cyst that ruptures will lead to severe pain and internal bleeding. And this can occur after sexual intercourse. So any kind of trauma to that area can cause cyst rupture. And the majority of the time, these are actually managed conservatively. So women will often present to A&E with this really severe one-sided lower abdominal pain, and they're investigated. And most women that present to A&E with lower abdominal pain will get a transabdominal and or transvaginal ultrasound scan to rule out any gynecological pathology. And these can often show signs that a cyst has been there and has ruptured, such as small amounts of free fluid in the peritoneum, or even a reducing kind of like cyst sac. And like I said, these are managed conservatively once the cyst has ruptured. So the actual pain will be the cyst rupturing, but that will settle pretty quickly. And these patients don't really require follow-up unless there looks to be something more sinister on the scan. So if the cyst looks like it could have malignant potential, or in postmenopausal woman, you would want to investigate this further. But as long as your woman is hemodynamically stable and you can clearly see evidence of a ruptured cyst and you have no other evidence that there is any other pathologies going on, then these women are managed conservatively. In terms of internal bleeding, then these women present in hemodynamic instability, this intense abdominal pain, and you will see the bleeding on ultrasound scan. And that will probably require interventions, but that's not something that's first line management for ovarian cysts, and often needs to be managed by specialists. So in terms of the different types of cysts then, so functional cysts are your follicular cysts, your corpus luteal cysts, and your thecal luteal cysts. And these are diagnosed when they're over 3 centimeters. So a normal like follicular cyst within the will come and go within the menstrual cycle normally, and it's normal for them to be up to 2.5 centimeters. However, when they're over 3 centimeters, they're then classed as a cyst. That's functional but not normal. However, most women are absolutely asymptomatic of these, and they just need reassurance and monitoring. But not particularly closely. They can be monitored kind of on a yearly basis. The risk of having these is actually reduced by taking the combined oral contraceptive pill. Then in terms of inflammatory cysts, so you've got your tubo-ovarian abscess and your endometrioma. So these are really quite common in younger women, and they're associated with pelvic inflammatory disease that we've just spoken about. And you might also hear of an endometrioma being referred to as a chocolate cyst, and that's because of its contents and consistency. Germ cell tumours are benign teratomas, or they're also known as dermoid cysts, and these are actually the most common ovarian cysts, especially in women under the age of 40. These will contain differentiated tissue, which sounds a little bit bizarre, but they can contain things like hair, teeth, muscle, fat, and even bone in some cases. And then epithelial cysts, these increase with age. So they're most common in kind of peri and postmenopausal women. But in terms of the management of any ovarian cyst, is if it's the woman is postmenopausal, or if there's any concerning features for malignancy, then they require further investigation. And if it's benign and they're asymptomatic, then you can just leave, reassure and monitor. So ovarian torsion, so this is a real gynae emergency. So this is where you get rotation of the vascular pedicle that supplies the ovary, and it compresses its blood supply. And this is considerably more likely with enlargement of the ovary as seen in the presence of an ovarian cyst. So it would be very unlikely that you would have a woman who has ovarian torsion if she didn't have an ovarian cyst. And actually 15% of the dermoid cysts present acutely with torsion. And that's why it's kind of important that you monitor these women who do have the cysts. You can reassure them and send them home, but they do require kind of yearly monitoring. So presenting symptoms of this acute onset of lower abdominal pain, nausea and vomiting. And diagnosis, again, transvaginal ultrasound scan. Most gynae pathology can be visualised best on a transvaginal ultrasound scan. So if you're not sure of what investigations you should be ordering, you really need to think about, or you could use transvaginal ultrasound scan, as it gives you a good view and is often first line investigation for most gynae pathologies. It'll show ovarian enlargement, free fluid in the peritoneum, and on Doppler ultrasonography there's venous flow abnormalities, and that's a reduced venous flow. So management of ovarian torsion, surgical exploration via laparoscopy with detorsion, and cystectomy is also appropriate. So if the ovary has become taut, you can go in laparoscopically, you can do a detorsion procedure, but if there's a cyst on it, you need to drain the cyst also. So the cystectomy, so you can drain it and remove it. It's important that you remove it, otherwise it's got potential to just come back, because if you don't, even if you sort the torsion, if you don't remove the cyst, then it's likely that it can occur again. So in terms of complications, ovarian torsion is just as severe and important to recognise as the emergency of testicular torsion. So within a few hours, infarction and gangrene may occur. They have a reduced blood supply, and these women will become very unwell very quickly. And if that's the case, you require removal of the necrotic ovary, and that's obviously can be detrimental to a woman's fertility, especially if she's already having fertility problems. So I'm finally going to talk just really briefly about toxic shock syndrome. It's not particularly something that gets covered a lot in medical school, and it's not something that will come up for a lot of marks if it does in finals. It's rare, but I think if I'm talking about gynae emergencies, it would be wrong to not include it. So it's an exotoxin mediated illness caused by bacterial infection. And there's two different types of toxic shock syndrome. So I'm talking to you about staphylococcal toxic shock syndrome, and that can then be further divided into two groups. And that's menstrual toxic shock syndrome, which is caused by the extended use of a single tampon. Or there's non-menstrual toxic shock syndrome, which results from a variety of staphylococcal postpartum vaginal and cesarean wound infections. So clinical features then, they get a rapid onset of fever, rash, hypotension and multi-system involvement. So this is really severe. They become very, very unwell, almost peri-arrest very quickly. And often toxic shock syndrome is kind of thought of once you, like, it's really difficult when a patient presents like that, you know, to think of toxic shock syndrome. It's really rare, and it's often diagnosed following history of retained tampon or tampon use that's been extended, or in any woman who's recently had a baby or a cesarean delivery. So in terms of management then, so these guys need to go to ITU, they will be often, if left this long, they will get to peri-arrest, and they need organ support. In terms of actual treating the toxic shock syndrome, you'd give clindamycin and oxacillin for 14 days, but that needs to continue, so it's 14 days after the last positive culture. So total length of antibiotics will be considerably longer than that, but they have to continue for at least 14 days after the last positive culture. And I think the picture just kind of shows this, this kind of peeling of the skin on the hands, which is really, really classical of menstrual toxic shock syndrome. And that's kind of 1 to 2 weeks after the rash develops. So if these patients are kind of taken onto ITU, given all the organ support they need, this may all happen still without a diagnosis. And when a diagnosis isn't achieved, but the patient's stabilised and ventilated and given organ support, they get this classical rash, and that's kind of a good indication that it's toxic shock syndrome. And obviously, if it is caused by extended use of a single tampon, the tampon should be removed as a matter of urgency. So I've finished talking about everything that I wanted to cover. So in terms of where I got my things from, so kind of Royal College of Obs and Gynae Green Top guidelines are really good. They tell you all about different evidence base behind all of their recommendations. And then the Obs and Gynae book by Lawrence Impey and Tim Child, and the 10 Teachers book. Then Almost a Doctor, Teach Me Obs and Gynae, and I really quite like using BMJ Best Practice. I think it's quite a nice resource, and I like how it's all set out, so I found that quite useful. But thank you very much for listening.